Hello and happy Teach Me Tuesday. My name is Lisa Houston, and I am here with another NICU education topic for NICU nurses from novice to experienced. Today, we're going to carry on our tradition from last week, which was shock, cardiogenic shock specifically. And this week, we're going to talk about hypovolemic and septic shock, which is going to probably feel more familiar to a majority of you watching. So let's talk about what shock in NICU's babies is. So when you think about shock, you're going to think about inadequate perfusion and oxygen delivery to tissues, which can lead to organ dysfunction. It can come from significant blood loss, severe sepsis, an overwhelming systemic inflammation. Our job as NICU nurses is early recognition and intervention. So we're going to walk through all of this today. We're going to talk about 6 key causes, things that we may see at the bedside, maybe that are happening at delivery or soon after the baby is admitted, talk about signs and symptoms, treatment, etc. So when we think about some of these key causes, right from the beginning, we need to think about that birth. And was there birth trauma that could contribute to this idea of hypovolemic shock? We also can think about birth in relation to septic shock, right? If a mom has chorioamnitis and the baby is severely septic, but we'll talk about that on the next slide. But regarding birth trauma, when you think about any of these hemorrhages, a ruptured umbilical cord, a knot in the cord where the baby's not getting their blood volume, a nuchal cord, a uterine rupture, a placental abruption, a previa, all these things, when you think to yourself, the blood that the mom has either goes away because the mom is bleeding or its pathway to the baby is inhibited. That can happen from uterine rupture, right? It can be inhibited. It can happen from placental abruption, when that placenta separates from the wall of the uterus where it has hopefully beautifully attached itself. So all those things are going to cause pronounced anemia and hypovolemia. Extreme prematurity also has many risk factors. Babies cannot regulate their blood volume well. We're taking blood volume from them. Then you put in this idea of sepsis, of insatiable water loss, capillary leak syndrome. So many things are contributing to our smallest babies, and especially that infection risk and things like neck, which we will talk about as well. So that brings us to neck. Neck is a time where I have probably seen septic shock and hypovolemic shock come on in a way I never could have anticipated my shift going. This is typically happened to me in a baby that we were not overly watching, right? We weren't so like, oh yeah, this baby doesn't look great. We've stopped the feeds. We've changed the feeding schedule. We've noticed we're on belly watch, whatever it might be. It's usually on a baby that's maybe hid some of those symptoms and then they come quickly. And if we're not responding quickly, the baby is going to get sick very fast. This is a situation once where I watched a transport nurse put an IV in a baby who the cap refill I think was 10 seconds. Like, it was terrible. But she got that IV in so we could start getting some fluid resuscitation going. Sepsis, again, same thing. I've seen the worst overwhelming sepsis actually come from babies who were in mom baby or newborn nursery or upstairs labor and delivery that maybe had some risk factors but didn't fall completely into the risk factor category, and their sepsis comes on so fast that they go into septic shock. And that leads to hypovolemia and overwhelming sepsis where the organs start shutting down. We're going to always have other things. Twin-to-twin transfusion, you're going to see serious hypovolemic shock going on there. Hydrops, think of that baby with all the extra fluid going on. Some of the craziest fluid resuscitations I've ever seen were in a hydrops baby. Pleural effusions, babies with paracentesis, thoracentesis. Think of those situations where maybe the fluid out and in is not the same. So what are we as the bedside NICU nurses looking for? So tachycardia is something maybe we're going to see right away. The baby's starting to compensate. Maybe they don't have enough blood volume. So remember, cardiac output, we talked about this last week during cardiogenic shock, is stroke volume times heart rate. So if our stroke volume isn't big enough and powerful enough, we're going to have to increase our heart rate. Hypotension is a late sign. It often signals the baby is decompensating. That prolonged capillary refill, I've talked about this before, but in regards to a surgeon coming into a bedside once and checking the baby's capillary refill and knowing that the baby was so far gone from neck that there was nothing we were going to be able to do with a capillary refill of greater than 6 seconds. So that just tells you, A, we did not have enough circulating blood volume, and it is absolutely not going to our less important organs at this point. Weak pulses, metabolic acidosis can also be a late sign. It depends on how much you're tracking and trending that, right? If you're doing blood gases frequently, maybe you're going to see that more quickly. But if it's a new blood gas that you're doing in the setting of the baby not doing well, it may already be so severe that we just don't know. Temperature instability, and then oliguria and anuria. I will say this until I am blue in the face. If your baby stops peeing or has a marked reduction in their urine output, we are in trouble. That means the kidneys are not perfusing. If the kidneys are not perfusing, there is a major underlying reason for that, and it may be too late because we are in organ failure now. And if it's one dry diaper is very different than a systemic day shift, 24 hours of decreased to no urine output. I strongly believe that all bedside nurses who are weighing diapers should be either watching in their EHR for what their urine output is or manually calculating it themselves. You should have an idea. We are ICU nurses, right? Neonatal intensive care unit. As an ICU nurse, it is our job to be paying attention to what the mils per kilo per hour output is for our babies. We do have new tools. We have these lovely things called our electronic health records that will often do this for us. So pay attention to that. Be watching for tracking or trending within that urine production. Our hemodynamic monitoring is going to be a huge part of this, of what we're looking for, things that the baby is going to tell us, the blood pressure, the cap refill, the urine output, and then obviously looking at our lactate levels, which we're going to need more from a blood draw. But we can see blood pressure, right? We can watch trending hypotension. We should be getting our MAP goals, making sure we know what those are from our provider. We can easily, cap refill is a non-invasive thing that we can check frequently and should be in a situation where an infant is not doing well. Urine output, again, cannot talk about it enough. I feel like I should just do a whole thing on urine output. I just don't know if that would, keep you all engaged as much, but let me know if you would like me to do that. And then again, our lactate levels. So what are we going to do? Fluid resuscitation is going to be our number one intervention. We're going to start with normal saline or lactated ringers. That's our first line of defense. This is kind of where the little bit of controversy comes in, is how much are you giving, how frequently, and how many boluses. So most typically you're going to see 10 mils per kilo. So if your baby weighs 2 kilos, you're going to give 20 mils. If your baby weighs 860 grams, you're going to give 8.6 mils, right? Typically we're going to see it over 30 minutes, and we'll maybe do it 2 times before we consider a pressor. I would say that's your most standard. If you want to pause and write that down, 10 mils per kilo over 30 minutes, 2 times before pressors. However, in a very small baby, you may run it over an hour. And a baby who is doing horribly, you may end up giving giving 20 mils per kilo, especially if they're a bigger baby and you have a very secure line. And if the baby is not doing well, you may be in more of a NRP situation where we're hand pushing over that 10 minutes. So just things to think about and kind of what that would look like for you. Know what your algorithm on your unit typically is of how you would increase these for your sick babies. We are not going to give dextrose boluses as a resuscitation for fluids. So if someone says dextrose, that should be a key that something isn't quite right with your order. Next, we're going to go to blood product resuscitation. Our PRBCs is usually the same dose, 10 mils up to 15 mils per kilo, usually over 2 to 3 hours, maybe 4 if you have a very small baby. Blood is only stable at room temperature for 4 hours, so it all depends on the time you received your blood. Very important thing to know. When did it come out of the fridge? That's when your clock starts ticking. Fresh frozen plasma and platelets, I have mostly seen in kind of those neck babies. I've seen cryo given with babies after a uterine rupture or placental abruption. So these are all things. Obviously, PRVCs are going to be the thing you see the most, but as we get into DIC, especially with a baby with severe shock and in septic shock, you're going to see more products being used. What are we also considering for our septic shock babies? So we need to know where to look for our infection and get those things out, which I've got down there at the bottom, whether that's a UA, a UV, an ET tube, something if we know what's going on there. We're going to be drawing our labs, our CBC. We have done 2 Teach Me Tuesdays on sepsis and signs of the left shift. So go back and rewatch those if you have questions about what to be looking for on your CBCs. Looking at your CRPs, CRPs alone are not always our best indicator of infection. They are not the gold standard. That's always going to be your blood culture or your urine culture, your culture. The word culture is what I want there. But your CRP can tell you, especially if it's very high, that your baby's infected, and you can watch it for trends. Obviously, we're going to be doing lots of ABGs. We're going to start them on those broad spectrum antibiotics, whether that's AMP, GENT. That's going to be your most common thing you're starting. If your baby is at risk for neck or we think it's neck, you may see something like Zosyn if they're going to go to the OR, something like Septic. So that's going to be, until we know exactly what's going on, what you're going to be seeing. And then getting out whatever we think the infection is coming from. Babies that have had issues in the delivery room, we need to be thinking about why they are at increased risk for hypovolemic shock. Severe birth asphyxia, obviously we may have a hypoxic injury. Cooling can also really affect what's going on with the baby's circulation, so something to think about. If you have a cooling baby, you may be doing some fluid resuscitation. If you have a massive fluid resuscitation in the delivery room because your baby has not done well, gone through all those steps of NRP where we're giving epi, we're giving our normal saline boluses, maybe we've gotten emergency blood and we're giving that, they are at risk for pulmonary edema and worsening respiratory distress. Those babies that don't get delayed cord clamping because they're not in a good spot, because they are not vigorous, if we want to talk about our NRP again, this can lead to lower blood volume and a risk for anemia. Prolonged shock before an intervention, that can be from sepsis, that can be from a late-term baby, it can be from an abruption or a uterine rupture where the baby is in severe distress. So kind of the longer that they're experiencing that, the more it's going to affect them. And then we need to be making sure we're watching those electrolytes really closely, especially if we're doing some interventions with blood and blood products that can also change the calcium levels going on with the baby. So if you are drawing and sending blood to the lab, or you have a machine like an iStat or a Chemate that's running that on your unit, making sure we're really watching those for the trends. How are we going to talk to our parents about this, right? Especially in the moment, this can feel so overwhelming, which is why in codes or in intense situations, we often have a role, admissions, same thing, where someone's job is to talk to the parents. That's a role if you have great role identification during high stress situation, codes, admissions. That way, you, the bedside nurse, can focus on task, and this friend of yours, whether that's you, a nurse practitioner, another nurse, a nurse practitioner, somebody else, a chaplain, coming over with the parents and being specifically assigned to answer their questions. So they could be asking about shock, they could be asking about the fluids, maybe we're getting blood consent for the first time. Why does my baby need blood? What are they at risk for? What are we going to be watching for? How will we know that they are doing better? Right? Explaining to them what the blood pressure looks like, what we want to see with the heart rate. And then, will my baby recover? And that's going to be hard in the moment when it's all going down and all these interventions are happening. Maybe you were on a 2-baby assignment that day and all of a sudden you're a 2 nurse to 1 baby. That's going to be very, very difficult to be like, oh yeah, everything's going to be great, right? Which we all know we never say, just like we never tell them when they're going home until they actually go home. So just keeping those things in mind. I think if I had a key takeaway for what I would want you to know about how to be with parents during something like shock or an increasing in care and escalation in care is to assign someone to be able to talk to them until you are done doing your tasks and the assignments that have come to you. So to recap, hypovolemic and septic shock are critical conditions in the NICU. I think we're more likely to see these in a typical level 3 NICU or level 4, not a cardiac ICU, more than we would see cardiogenic shock. Hypovolemic shock is from lack of fluids, lack of blood. Septic shock occurs due to severe infection that causes systemic inflammation. We're going to watch for tachycardia, hypotension. We're going to give fluids. We're going to monitor the baby. We're going to be drawing lots of labs. Very, very, very likely, I'd never say anything's 100%. If you are experiencing this and the baby was not intubated, they will end up intubated. We need to be watching those urine outputs and educating our parents. If I could ask you to have 3 takeaways from today, the 3 takeaways I would want you to know are: what are the signs and symptoms and how important urine output calculation is as an NICU nurse working in a critical care situation unit, right? Know your baby's urine output, your patient's urine output. Number 2, what would you expect for immediate fluid resuscitation orders to look like, knowing the difference between someone ordering normal saline or lactated ringers versus dextrose? What would you anticipate to be the dose and the time for them to run over? Again, most likely we are starting with 10 mils per kilo over 30 minutes, typically giving 1 or 2 of those before we would go into pressors, which we talked about last week when we went through cardiogenic shock. And if the baby really converts to that, especially from septic shock, go back and watch that and you'll learn all about your pressors. And number 3 is that during any of these high critical situations is assigning someone to be specifically in charge to communicate with the parents and answer their questions. Thank you for tuning in today. I hope you join me next Tuesday for another round of Teach Me Tuesday. Please make sure you like and subscribe so that you can continue to see these videos, and I will see you next week.